to get right into EMCCS. And without any further ado, the boss, the man, Dr. Jaime Moran.
Hello, my name is Jaime. Thanks to Dr. D'Souza, Wendy, and Dr. Leon. So, quick snapshot. We have a 56-year-old male who was brought in by EMS after being found unresponsive. He has a recent admission for pneumonia, and he has a history significant for HIV, CHF, hypertension, and hyperlipidemia. So, a little more detail. Syncopal episode, he was found unresponsive on the floor by his girlfriend. He's reporting a little bit of lightheadedness, a little bit of weakness, and a little bit of shortness of breath. No chest pain, no fevers, no chills, no diaphoresis, no incontinence.
So he came to in the ambulance, or was he was unresponsive and then?
He woke up in the house. Past medical history, AIDS, CD4 count of 4. Last CHF, last EF of 45 to 50%, has hypertension and hyperlipidemia. So significantly, he had a recent hospitalization for a BAL-proven PCP pneumonia. At that time, he was found to be HIV positive and started antiretroviral therapy. Of note, he had actually been HIV positive for many years. There was a positive HIV lab from many years ago. Apparently, he was called. He never got the phone call. A telegram was sent, but he never received it. So he's on these antiretroviral therapies, aspirin, metoprolol, etc. Atopiquone. Does anybody know what atopiquone is?
Malaria.
PCP prophylaxis.
And PCP prophylaxis. Good. Any questions about the HMP up until this point?
How old is he again, sorry?
56.
56. Any other questions? So three had vital signs: heart rate 93, respiratory rate of 22, no intensive, afebrile, setting 94%. About 7 hours later, anything significant?
Pulse oxygen.
How is his respiratory rate still 18? Why is he not taking?
So initial assessment. Areas intact, he's answering questions. Some RALs in the right middle field. He's hypertensive, and he's a little confused. Do any of my juniors want to help with a preliminary problem list? Should I call him people?
Hypertension.
Thank you. Anything else? Thank you. Good. Exactly. Hypertension, altered static syncope, and we'll put H on there. Initial interventions. What would you do right now? Yeah, sounds good. Monitor IV axis, IV fluid, and he came in with a syncopal episode, so let's get an EKG this one. One PVC, but otherwise no. So general, he's laying in bed. Like I said, he appears slightly confused, and he just kind of has this generalized weakness. Atraumatic, there's no JVD, tracheal midline. This is all taken from the note. Some RALs in the right middle field, as mentioned. Belly's non-tender, non-distended. No alerts from the edema. The provider had maybe some difficulty palpating pulses, but he does have a pulse. No focal deficits, and generally speaking, his motor strength is intact.
But there was no further mention of like mental status in terms of confusion or maybe a little more focused mental status exam?
Just a little confused, but a normal neuro exam otherwise. Yeah. In the past, but nothing recently, nothing currently. Any other questions?
Is he giving us surrogate assistance, or is he being corroborated?
I'm sorry, repeat that?
Is he giving us answers to the questions, or is it being corroborated
He
by
is.
somebody else?
He is. He's speaking like fairly coherently, and he's giving a decent history, basically saying that he doesn't remember falling. He was just in the room, and then he woke up on the floor.
How many days ago?
It was prior to arrival.
Sure.
Differential. All right. Anything else? Good. Anything else?
Acute blood loss is not obvious.
Good. Anything else?
Arrhythmogenic syncope.
Yep, very good. All right,
Long
so,
QT, like that arrhythmogenic from all of his antiretrovirals.
definitely. So yeah, sepsis, PML, immune constitution syndrome, and then all of our causes of syncope, right? Arrhythmia, PE, could it be a CHF exacerbation, ACS, or could it have been a seizure?
Immune reconstitution.
So by this point, he's gotten about 2.5 liters of fluid in a pot A. He's actually relatively alert and comfortable, medicating well after the 2.5 liters. He's still pretty hypertensive.
Give steroids.
So at this point, we're not doing.
Have any of his temperatures been rectal, or are they all oral?
They're all oral, no rectal temperature.
He didn't have any head injury or neck injury or spinal injury or any sufficient for neurogenic shock.
It's
No, good
adrenal.
question, but no.
That's adrenal insufficiency or calcium channel blocker.
Any other thoughts?
TBA,
Lots of finger
adrenal
sticks.
lab.
We should go die if we don't get steroids.
How many do you guys have a finger stick?
It was normal. So what else do you guys want to do?
Hand scan the school.
Yeah, we just look at that.
Vasopressors.
Any specific labs?
Cortisol.
Oh, lactate.
It would be good.
We do something. This is all why we're already intervening on his hypertension.
Yep. Okay.
The ICU is probably someone we should consult.
Good, thank you. I see consult.
Maybe ID. He's a complicated patient.
ID, definitely. All right, so here's this VBG. It's a little acidotic. Potassium 5.5. Lactate 1.4. It's okay. His creatinine is a 6.7, which is high for him.
Potassium, sorry.
Cloning's negative, so that's good. He's normal. Again, we have hyperkalemia, immune creatinine are elevated. A little bump in some of his LFTs.
Anion gap of 17.
And I got
17.
no, there wasn't. At least not when that was documented.
Oh, he's got a faggot sign.
What do you think? Yeah, the right side doesn't look good. So refined problem list. Looks like a pneumonia, renal failure. He's been fluid resuscitated at this point, but he's still hypertensive from septic shock. And he has AIDS, right? Over AIDS. So ED course, antibiotics are ordered. He gets vancomycin, Cipro, Bacterial. Gets transferred to CCT. He gets a total of about 5 liters. After the 5 liters, he's 60 over 40.
Need steroids.
Did not get steroids. He gets started on levofed. He's still 70 over 50, and finally he gets put on epi, and it goes up to 93 over 61. Interestingly, I mean, after the initial fluid bolus, he was actually mentating fairly well throughout this entire time.
Is that with the central line?
Yeah. The CAT scan of his chest. Yeah.
Did they do an NCT?
I'll get to that. But yeah, they did. So yeah, I have basically a knee consolidation in the right lower lobe. According to the attending radiologist read, is a little atypical for PCP. So according to the radiologist, probably more of a bacterial pneumonia. PET CT was done. It's normal.
With contrast also, or just without?
Without. Good question. So he gets admitted to the ICU. Gets diagnosed with HCAP with acute renal failure. The Bacterial is switched to etobicoline, which, like Taylor mentioned, is also used for PCP. The reason they use etobicoline is because on his prior hospitalization, he developed hyponatremia and hyperkalemia that was thought to be potentially related to the Bacterial, so they switched it. He's on now azithromycin for MAC prophylaxis. His retroviral therapies are held secondary to the renal function. However, he improves, and by hospital day 4, he's off crosses and downgraded. Renal consulted, they think it's more of an acute on chronic disease, likely secondary to his hypertension. They recommend medical management. IDs such as continue with the antibiotics and restart his antiretrovirals once his renal function improves, which it ultimately does. Comes back to 1.4. His retrovirals are restarted, and 9 days later he's discharged home. Yeah.
Does the etobicoline count as double coverage for HCAP beyond the azithromycin?
Etobicoline?
No.
Yeah. So they're saying it's HCAP and they only give him azithro.
No. So I'm sorry. He was continued on the bank, the Zosyn, and the Cipro.
Those are continued on.
Yes. Good question. So final diagnosis: septic shock secondary to HCAP. And he's missed his follow-up appointment since.
That is crazy. How did that guy survive?
Yeah. Yeah, and surprisingly, he was maintaining well like this entire time.
Wow.
Any other thoughts or comments?
No steroids over?
No steroids.
What was the thought behind the Cipro? So bank goes in Cipro and,
So I think that's a great question. I'll get to it in a few. But that's an excellent question. Anything
You're
else?
asking for steroids for PCP?
Very adrenal, so the hypotension.
For the acute reconstitution potential, or the fact that he was persistently hypotensive at normal cardiac or low heart rate in this type of fluid?
So interestingly, those two differential diagnoses were never brought up in any of the notes, any of the ICU follow-ups. ID never mentioned it, but I think that should have been a consideration.
The initial blood gas, is that venous or arterial?
It was a VBG. An ABG wasn't obtained until after he was admitted to that ICU.
And he was responsive to the fluids and epi?
No.
The last blood pressure was low. Was he ever respond? Did he ever go on
After the epi. After the epi, he responded to systolic above 90 and then improved after that. But no, he remained hypertensive until the epi was finally started. And he had received a total of 5 liters worth of boluses.
Is there any talk about doing LP?
In LP? No. According to the providers, so the IBM was done by a rotator, so I wasn't able to speak with him. He writes in his note that the patient overall looked a little confused and a little altered. According to the attendant who spoke with him in Pod A, and according to the CCT attendant, he was actually mentating fairly well. And he looked relatively comfortable despite being hypertensive.
Yeah.
Any other? Okay, so yeah, critical illness in HIV/AIDS patients. I'd like to discuss the most common etiologies for ICU admission in these patients, with a particular focus on respiratory illness, in particular PCP, bacterial pneumonia, and HCAP. I'd like to briefly go over immune reconstitution and inflammatory syndrome, and just briefly touch upon the increased risk of cardiovascular disease in a lot of these HIV and AIDS patients. So, like Sally referred earlier, this is a lot more of a chronic disease nowadays. Greater than 1 million people in the U.S. with HIV or AIDS, and roughly every year there's at least 1 million ED visits for AIDS patients. So we're definitely on the front line in managing this disease. This systematic review just published last month sought to review the most common etiologies for hospital admission in general in these patients. And despite the fact that it's a chronic disease and that these individuals are having just as much causes of non-AIDS related illnesses, AIDS-related infections and bacterial are still by far the most common etiologies. In our region, the Western Pacific region, this trend holds true, this trend follows. Specifically regarding AIDS-related admissions, TB is at the top, along with candidiasis, PCP pneumonia, and toxoplasmosis. Bacterial infections obviously are pretty important, the most common being pneumonia, isolated bacteremia, or infectious diarrhea. Regarding the major causes of mortality for these patients, again, AIDS-related and bacterial are by far the top two. And among people who are admitted to the ICU, it's no surprise that they suffer up to 36% mortality in comparison to the ones who aren't ICU admitted, who their mortality ranges in around 17%. Specifically in the United States, in the HART era, respiratory failure, again, is by far the most common reason for ICU admission. Along with sepsis, we have CNS dysfunction, GI problems, cardiovascular disease, and immune reconstitution inflammatory syndrome. Obviously, the respiratory complications, the differential for HIV is incredibly broad and wide. You have to do consideration for the infectious etiologies, you have to consider non-infectious, and the HIV-related neoplasms. I'll focus on the PCP and bacterial. So PCP pneumonia, right, it's a fungus. Exposure occurs during childhood. Up to 2/3 of children by the age of 4 have antibodies to PCP. It then remains latent unless the patient becomes immunocompromised. It usually only occurs when the CD4 count goes below 200. So in a lot of these patients who come to the ED, if for whatever reason we decide to discharge them and we know that their CD4 count is below 200, it probably wouldn't be a bad idea to make sure that they're on Bactrim for prophylaxis. According to the IDSA, Bactrim also confers some resistance to, or confers a protective benefit for bacterial pneumonia and toxoplasmosis as well. A lot of these PCP patients also have a lot of co-infections like bacterial pneumonia, Kaposi's, and oral candidiasis. The clinical presentations we're relatively familiar with, right? The gradual onset, the fevers, non-productive cough, shortness of breath, and some freckles on exam if the exam isn't normal. The chest X-ray, right? We're told of this diffuse bilateral interstitial type of pattern. However, atypical radiographs are also happening quite frequently. An HIV patient with spontaneous pneumothorax should immediately raise a suspicion for PCP pneumonia. Here we have a typical looking radiograph. The two most common abnormal labs obviously would be the CD4 count below 200 and an elevated LDH. The elevated LDH believed to be to reflect the degree of lung injury as opposed to the overall burden of organism. Definitive diagnosis probably isn't something that we would be doing in the ED because you need specific respiratory specimens. In particular, BAL has a relatively good diagnostic yield. Something we can, however, get in the ED is a CAT scan. It will show this like diffuse patchy type of bilateral infiltrates, this ground calcification type of pattern that's commonly spoken about. So treatment, IDSA guidelines, like Dr. Granchamer mentioned earlier, are great. They're easily accessible. So the preferred therapy is obviously Bacterial. Interestingly, if a patient on Bacterial prophylaxis still develops PCP, you would still treat them with the weight-based regimen of Bacterial. Many of the juniors know the indications of steroids in a PCP pneumonia patient.
Hypoxia.
Hypoxia, good. Yeah, so steroids. PaO2 less than 70 or an A gradient greater than 35. Prednisone is the preferred agent, or you can also use methylprednisolone. A recent Cochrane review earlier this year showed the number needed to treat to prevent one mortality is 9 in countries that don't have antiretroviral therapies, and it's 23 in countries that do have access to this therapy. So moving on to bacterial pneumonia, it can occur at any stage of HIV infection. Obviously, it would be more frequent in people with advanced immunosuppression and those with a low CD4 count. You'll have the typical risk factors that predispose people to bacterial pneumonia, with smoking in these patients conferring greater than 2 to 5 times risk of developing pneumonia. They suffer from some of the common pathogens that you would expect, with the added caveat that Staph aureus and Pseudomonas has to be a consideration. Clinical presentation, right? Acute onset, fevers, chills, rigors, chest pain, projective cough, and shortness of breath. So the treatment of an immunocompromised patient with pneumonia is completely different than your run-of-the-mill community-acquired pneumonia. Basically, these patients are considered, you would treat them just like you would an HCAP. These are the IDSA guidelines. And just like Dr. Granchamer mentioned, the big concern is that they have drug-resistant pathogens. Some of the guidelines include antibiotics in the preceding 90 days, a current hospitalization of more than 5 days, high frequency of antibiotic resistance, chronic dialysis within the past month, which a lot of our patients are on. And the last one there, importantly, is the immunosuppressive disease or therapy. Our patient had multiple of these. So to answer Melanie's question, it's double coverage, right? Double coverage for Pseudomonas. You have your cephalosporins, you can use your carbapenems. It's just not bank dosing, which we often do. You want to add that third agent. There's a little bit of controversy whether or not this actually confers a mortality benefit or not. However, it's still suggested by the IDSA guidelines, despite no proven benefit. If you're considering a respiratory fluoroquinolone between an aminoglycoside agent, the aminoglycoside agent has higher risk of nephrotoxicity, and so you would probably want to err on the side of caution with the fluoroquinolone. We have easy access to this. Our MR antibiotic guide basically echoes the exact same thing that the IDSA guidelines state. So immune reconstitution inflammatory syndrome can have high mortality rates up to 20%. I think this probably should have been on the differential of this patient. Ultimately, ended up being bacterial pneumonia, but it was definitely a consideration. Just to briefly go over the pathogenesis, what this slide is showing is on the left you have high HIV RNA levels and low CD4 counts. Basically, as soon as you start the antiretroviral therapy, you have an increased immune response and an associated increase in inflammatory markers. So basically, the pathogenesis of iris is an exaggerated immune response. However, more specifically, it's an exaggerated immune response to an underlying infection. So there are two types of syndromes out there. One is the unmasking, where the patient already is infected with an opportunistic infection. It's just that there are no signs of that. The signs don't actually develop until he started on the antiretrovirals and his immune system recovers. The second type is the paradoxical worsening, where it's known that he has an infection. He's being treated for that infection. Antiretrovirals are started, and he gets worse. And it's all thought to be basically due to basically an inflammatory marker response, a cytokine storm. There are no set criteria for the diagnosis of immune reconstitution syndrome. There are only some general guidelines. Obviously, he has to have, the person needs a diagnosis of HIV. They need some sort of evidence of response to antiretrovirals, so either seen through CD4 improvement or viral load reduction, clinical deterioration in their disease, a temporal association with the start of antiretrovirals, and overall diagnosis of exclusion. The treatment is mainly supportive and steroids, like Nico was alluding to, with prednisone being the agent of choice. And finally, just to briefly end with cardiovascular disease. Basically, it's more of an inflammatory, it's more of an immune response based on direct and indirect factors from HIV. HIV itself confers pro-atherogenic properties, pro-inflammatory properties, pro-coagulopathic properties, which all basically induce a smooth muscle proliferation and just basically an increase in atherosclerosis. And then we also have the secondary effects of the antiretroviral therapies, which basically cause an overall metabolic dysregulation. So what ends up happening is that a lot of these patients, they're suffering from acute coronary syndrome at a good 10 years before the rest of the general population. The treatment of choice is the same, obviously with revascularization, CABG, PCI. Unfortunately, because of the underlying mechanisms of their increased risks, they are at higher rates of stent restenosis. So basically, we already have a low enough yield to working people up for ACS, but definitely people with HIV and AIDS fit this demographic. Yeah, so just some basic take-home points. Right, respiratory illness is still the #1 cause of morbidity and mortality in a lot of these sick HIV/AIDS patients. If you're considering PCP, Bacterial and prednisone, especially in the sick patient, you have to remember your HCAP guidelines for these patients. Treat them aggressively, treat them with double coverage. Iris is always a consideration, it's always on the differential, but really it's just supportive and a diagnosis of exclusion. And these patients are at increased risk of cardiovascular disease. Any questions? Yes.
That was wonderful. That was great. I just wanted to add, I saw you put TB up there. I think that we often forget about TB, but we should really remember that HIV and TB are cousins. And though we don't see it frequently here in this country as much as when you travel and you guys are doing your international trip, we should also remember TB. Because it's, the resurgence of TB, especially in New York City, came with the HIV epidemic. And a lot of our patients who are undomiciled, staying in shelters, coming from Rikers Island, or even just in the community of New York City in general, are at risk for TB. And so I think oftentimes we're forgetting about TB, but there's a huge risk factor. To think of it as a cousin of HIV. So we had a patient yesterday who had a right upper lobe infiltrate for months now to the CD4 of 1, and no one was thinking, maybe this patient has TB. So just don't forget that as well.
I don't know if this patient was tested. Any other questions, comments? Thank you.